Good afternoon. I'm Faiz Bora, and it's my honor and privilege to welcome you to the 2021 STS Residents Symposium. This has been a unique year, and we have a unique program planned for you. This is the first virtual program of the Resident Symposium. I wanted to thank our team. There's been a lot of work behind the scenes to put together this, what I hope will be an excellent program. My thanks to the STS team, particularly Beth Weiner for all her administrative support. Particular thanks to my co-chair for the symposium, Dr. Betsy Dexter, as well as Elizabeth David for her support. I particularly want to thank all our speakers, moderators, for their time and their efforts in putting this program for you. We have 5 themes, 5 talks, which will be moderated. You will have a chance to send in your questions through the chat. We hope to stick to time. The 5 themes are how to set yourself up for success during residency and beyond. Number 2, academic and private practice, employment paradigms. Number 3, key steps to finding the right job. 4, personal and financial security. And 5, achieving a work-life integration and wellness. So we have a packed program for you. We're absolutely delighted that you're here. And without further ado, I will hand the podium, the virtual podium, on to our first group, which will be moderated by Joe Turek.
Well, I'd like to also welcome everyone to this session. I think this should be a very informative session for all. I'd like to welcome 2 of our panelists here, Drs. Melanie Edwards and Arne Giersen. In this session, as Dr. Bora had said earlier, we'd like to address the topic of how to set yourself up for success during residency, but also beyond. And so I want to thank both Drs. Edwards and Giersen for being here for this. So I think we'll just jump right into it. To give our audience some perspective on your individual journeys as cardiothoracic surgeons, could each of you provide us a brief background of your training path and where you are today? We'll start with Dr. Edwards.
Dr. Turek, could I just make a comment first? I'm sorry to interrupt.
Please.
We just wanted to let the participants know that you can put questions into the chat box, and our chat moderators will be answering them as the talks are going on. So please do put questions in the chat box. Thank you.
Hi, thank you, Dr. Turek, and thank you to the planning committee for the invitation to participate. So I came to cardiothoracic surgery through the traditional pathway. I did a 5-year general surgery residency, did not enter general surgery with the intention to do CT surgery, but really fell in love with the thoracic oncology and foregut aspects of what I currently do. And so I did general surgery at Beth Israel Deaconess in Boston, and then my CT surgery at St. Louis University. Currently, I'm in private practice in a multi-specialty group. We work out of one hospital in the Ann Arbor region. I have one partner who's a general thoracic surgeon, and it's a great practice. We do pretty much everything and have great support from our hospitals. So.
Yes, yeah, thanks. I appreciate the opportunity to participate. Yeah, my name is Arne Giersen. I'm an adult cardiac surgeon. I'm actually the chief of cardiac surgery at Yale. I also went through the traditional kind of training. Early on, before in medical school, I realized I wanted to be a cardiac surgeon, and did my general surgery training at Yale. I did my cardiac surgery training at University of Pennsylvania, and then have pretty much been in academic practice since then at Yale, with a brief hiatus when I went for 4 years back to Iceland, where I'm originally from. But we're part of a big, fairly large group in my division, there are a total of 13 faculty members at various different levels, and kind of busy adult practice.
Fantastic. Well, I wanted to talk a little bit about mentorship. You know, mentorship is clearly an important ingredient to the success in any profession. However, finding the right mentor is not always an easy undertaking. So could each of you talk about the mentorship that you were fortunate to receive and provide any wisdom on how you can find the right mentor in this field? Also, is there a difference in your mind between a mentor and an advocate? And maybe Dr. Gearson could start off this time.
Yeah, I do believe, I think no matter what you take on, and you really should have a mentor or somebody that you can kind of reach out to and kind of help you reach your level. I think you can have different mentors at different time point, whether it's in residency as a junior faculty or later on as a senior faculty. And even I would say I've had throughout my you know, who I've have basically followed me through the general surgery. I've been mostly at Yale, so a lot of them I met both at Yale and then also when I was during my fellowship training. I think there is a difference between a kind of advocate or a mentor. They can sometimes be the same person, but not always. And all I can say that I think you need to reach out to certain people. You don't have to, and you develop relationships slowly. And a lot of the time there are some common kind of an interest and things that align yourself with your mentor. So don't feel afraid to, how you say, not, you know, approach somebody, then later on you realize that's not going to be a mentor, then move on. You want to have somebody who is interested and committed in you, and at least has your interest at heart and can give you good advice. Thanks.
Before we go to Dr. Edwards, there was a question in the chat for you, Dr. Gearson. Could you speak a little bit about how international medical graduates can help set themselves up for success given the additional challenges?
Yeah, I think certainly international graduate for international graduates as US graduate, except you have to kind of get your foot in the door. I mean, you have to work hard. You generally have to do some, you know, some connections that get you into a certain programs, whether that's to research, personal connections, faculty at your own institution, abroad, connecting to an institution in here in the US. That's kind of how I was able to get started at Yale. And you know, there are challenges, but you know, keep in mind, I think a significant portion of all physicians who practice in the US are IMG.
That's a great point. That's a great point. Dr. Edwards, could you talk to us about your experience with mentorship?
Yes, certainly. So I think most of my mentors have been traditionally the individuals who I've trained with, but also along the way I've met different individuals through specialties at meetings, and so I think it's a process as you go along. One of the things that I would suggest, because I wasn't particularly intentional about this, but I think it is important to be very intentional about what your specific goals are and understand that you'll have a research mentor, maybe someone who will help you in a certain clinical area, and that this will change as your career develops and as your needs change. One of the differences you mentioned between a mentor and an advocate or sponsor is this person is going to actively promote you. This is the individual who's going to suggest you for committee assignments and you know, advancement in your career, and definitely put your name up. And so you need both, and the same person can exist as both, but I think you also need to as residents, be mindful that you yourself are responsible for that mentorship relationship. You are the one who's driving it. And so you have to show up, be intentional, set your goals for the mentorship relationship, and then follow through with the things that you've promised.
Well, I think that's great advice. Mentorship is not going to necessarily fall in your lap. You really need to go out and actively look for it and look for the right mentor. Sticking with you right now, Dr. Edwards, I wanted to ask a question about important things for residency. So what would be, in your mind, the 5 most important pearls that you could give for how to be a superstar resident?
Yeah, well, I'm sure everyone kind of understands these, but these are mostly intuitive. But what I would say is be open-minded to the idea that you can learn from everyone. So, not just your attendings, but your fellow residents, your fellow trainees. I learned bronchoscopy tips from a respiratory therapist in a sim lab. So, be very open to that. Treat everybody with respect. That's capital that's going to come back to you when you need it, and really helps you to function in the hospital in a more effective way. It goes without saying, work hard, don't complain, be a good team member. And another thing is be prepared for the operating room. Check in with your attendings before cases, even routine ones, because there may be nuances that you may not understand. And you can be more engaged in the operating room if you're more engaged before you get there. And also, don't be afraid to ask questions. This will require some preparation because there is some baseline knowledge that you're going to need, but there are a lot of nuances and things that we do that we may not necessarily think about that may be helpful. Why this approach, because, you read a textbook, there are, 5 different ways to do things. Why did your attending pick this in this particular situation? You can learn a lot from that.
Yes, thank you. Those are some excellent points. Dr. Garrison, I'm sure many of yours would overlap with that, but be interested in the group hearing what some of your pearls are for residents.
Well, I kind of had the same kind of main themes in mind, so I don't want to add much to that, except I do believe, obviously, integrity is extremely important for residents. Everybody makes mistakes during your training. Just step up and admit sometimes that you made a mistake, and just stay truthful about it. That's the worst thing that you can do as a resident, is not to be truthful about stuff. And try to identify your passion. What is really that you're passionate about, and make that kind of drive you forward a little bit. It's like identifying a goal that you're aiming towards. You'll never be good at anything unless you have a certain passion for it.
Yeah, I completely agree. I think you need to be doing something that you really want to do, and it's important to find your passion and realize that there are a lot of individualized tracks that you can have within our profession, which is one of the nice things about what we all do. Moving on to the next question. Residency and fellowship can be quite overwhelming, and I think all of us have felt at times like we're just trying to keep our head above water in the process. And the day-to-day tends to consume us in these moments. However, it's really undeniable that it's important to have a broader perspective during training and to engage in additional opportunities that will help to contribute to our career beyond training. So in retrospect, based upon your experiences, what was the most important opportunity that you took advantage of outside of the traditional part of training that contributed to your career success? And we'll start with Dr. Gearson on this one.
Yeah, I do believe that if I'm saying one thing that really contributed to my success, I think was I went to a laboratory, and during my lab years in general surgery, I worked with Graham Hammond, a senior cardiac surgeon who was, kind of in his latest stage of his career. And he really was, first of all, kind of ignited the passion about setting up doing basic science research and venture into academics. But really, he was a real sponsor for me. I wouldn't really consider him a mentor, but he was my main sponsor, who pushed me to get into great training program, and later on to the faculty position and setting on the pathway that I'm currently on. So if I'm saying that there's a single person that I think, there were multiple people along the way in my training that I, especially in cardiac surgery training at Penn, were really instrumental in how I am and as a surgeon. But I say that the pathway to doing academic cardiac surgery was Graham Hammond and joining his lab.
Fantastic. Dr. Edwards?
Yeah, so during training, I had the opportunity to spend time at another institution, and it was a really fascinating experience. While much of what we do is pretty similar, it gave me a different perspective into, different practice models and, different ways to run an operating room. And so for me, that was a valuable kind of a perspective lending experience.
So we're running close here on the end of this session, and I wanted to answer one more question that we had from someone in attendance. The question was that I've heard from many attendings that roughly 40 to 50% of people end up leaving their first jobs. What do you think about this? Why does it happen, and what can we do to avoid this? Dr. Edwards, if you want to start off on this one.
Yeah, I mean, avoid it, you can, but I don't know that that's necessarily a bad thing. All the residents here, when you were in medical school, you had no idea what residency training was going to be like until you were actually in it and doing it. You had some idea, but you really didn't. And so your first job might be an opportunity to learn the things that you do enjoy about practice and don't. I think if you avoiding it is your goal, then certainly having very clear and well-defined goals going into the job search can certainly help. So that would be my suggestion in that regard.
Dr. Gerson, I'll give you the last word on this.
Yeah, no, this is an excellent question, and I think this is something that's difficult to, this is common and probably continues to be. I think the main issue is to, when you start applying for a job and looking for a job, make sure that your vision and the vision of the place where you go into kind of align, whether that's and then it's from multiple standpoints, and the expectation that you have are aligned with the expectation that they have. So I think that's, but it's always challenging, and I'm sure you take a job and you realize that there's certain things that were not exactly that you wanted, or maybe you are not exactly what they wanted. It's really challenging, and that's probably the most trickiest part of actually finding a job and taking on your first job.
Well, that's fantastic. That was an excellent session. I really appreciate your time and really thoughtful answers. And I'll throw it back over to Drs. Bora and Dexter for the next session.
Are you able to hear me, guys? Excellent first session. Before we move on to our next topic, we have 4 poll questions that we would like to share with you. This will give us an idea as to who the audience is and also some background thoughts. So we'll share these questions with you now online. It's about 15-20 seconds for responses, and then I'll quickly run through the poll results with you before we move on to session number 2. Beth, are you ready for the questions? It's question number 1. Indicate your current training status. Okay, so results, bulk of our participants is expected are CT residents, fellows, as well as general surgery residents. It's nice to see a healthy population of general surgery residents as well. So welcome. Question number 2. Indicate your current training status. I think we need question number 2, Beth. Indicate your PGY year. Okay, spread throughout from 1 all the way down to 9, with perhaps the biggest number being 5s and 6s and 3s. Great. Next question, please. Question number 3. Indicate your current training pathways, either traditional, integrated, or other. Okay. That's interesting. Bulk of our participants are in the traditional pathway, and a small percentage are in the I6, and few are in the 4+3. I'd be interested to know what the others are. And our final question. Long-term career goals. Short and sweet. If you know it, please answer it. Wow. Academic 73%, 7% private, and about 20% are undecided. I'll tell you that most models are sort of hybrid models right now, and which will really lead us to our next session. And that is academic and private practice employment paradigms, moderated by my friend Lenny Lee. And I'll let Lenny take away the session. Thank you.
Can you hear me? Okay, great. Thanks very much, Faz. I want to thank Drs. Bora and Dr. Dexter for the invite, and to the STS for hosting the program. We do all realize that this is a difficult platform to do these programs in, so we appreciate the efforts. So as we all, as the residents and trainees start nearing the end of their training, so begins their search for employment. So obviously there are many factors that play into the decisions as to jobs, geographic locations, type of practice, compensation, and academic versus private, as you saw in the last question. So historically, and I think Dr. Bora just touched on this, historically the distinction between academic practice and private practice has been fairly sharp. However, with different employment models, we see different practice models, training paradigms, and therefore the line has largely been blurred between academics and private practice. So you'll see the slide that's up. We hope to touch on most of these things during the session. And so I'd like to welcome 3 people. We have our 2 panelists, Dr. Marissa Savasco and Dr. Michael Robich. I'll give them each an opportunity to introduce themselves. And finally, we have Dr. Alan Pickens, who is associate professor and minimally invasive thoracic oncologist, who is currently at Emory and will serve as our moderator for the live chat questions. So, Mike, Marissa, you want to introduce yourselves and what kind of practice you're in and where you are?
Great. Thank you, Dr. Lee. I appreciate that and appreciate the opportunity to be here. My name is Michael Robish. I am an adult cardiac surgeon. I practice at Maine Medical Center in Portland, Maine, which is traditionally sort of a private practice. However, it has started to become more of a hybrid situation. I have a lab and I do research, and I've been here for 5 years. I finished training in 2015, and the focus of my practice is general adult cardiac surgery. As a matter of fact, I started my practice just doing pretty much everything. It has slowly been focusing more and more on structural heart disease, mitral valve disease, and HCM, septal myectomies. And so that's sort of how it's been evolving over time.
Great. Marissa?
Hi, thanks, Dr. Lee, for the introduction. I'm Marisa Savasco. I'm an adult cardiac surgeon at Penn. I do general adult cardiac and have a focus on transplant and mechanical support. I've been at Penn since 2019.
So I'll ask each of you to weigh in. How do you define an academic practice versus a private practice?
Well, I suppose, you know, in my mind, at least, the academic is one that has sort of defined educational and research responsibilities in addition to the clinical responsibilities. As I say, I do have a lab and do some clinical outcomes research, but we don't train cardiac surgeons here. And so I think at the end of the day, that's probably for me, it's one of the biggest differences.
Yeah, and I'll just echo that. I mean, for me, academic medicine is the ability to train fellows and residents and take people through cases and be involved in medical student education. And so to me, when I think of academics, I generally think of teaching. Of course, there is a research component that is part of academics as well. And then, you know, as Mike said, although this may be changing, you know, I think academic centers are tertiary care referral centers, and occasionally we have a higher level of complexity in the patients that we see, perhaps because we have more resources in-house all the time. And so the level of acuity or the complexity of patients may be higher at some academic centers relative to some private practices. But again, this could be changing too.
And Marisa, how would you see pursuing a specialty like transplant and mechanical circulatory support in an academic environment versus more of a private practice environment? And I'll ask the same to Mike regarding things like structural heart.
So when I was looking for jobs, you know, I had a geographical constraint, you know, the Northeast corridor, and there are some, you know, busy private practice groups that do heart transplant in particular. And so I think it's possible. I think there are busy private practice groups that do transplant. I think it's more common in academics. So I don't think you're limited to academics if one wants to do transplant. But it might be easier to find. There probably just volume alone in terms of the number of jobs out there. There might be more within academic centers. Now, in terms of mechanical support, you know, not just for VADs, but for ECMO and cardiogenic shock patients or these lung rescue patients, you need perfusion in-house often, and that might be a little bit harder to come by within private groups. But again, I was kind of limited to this Northeast corridor, and that was just my experience.
Mike?
Yeah, so for me, it was sort of interesting in that I'm in a group of 6 adult cardiac surgeons, and I wasn't necessarily hired to do structural heart work, but I had an interest in it. And so for me, it was just sort of paving the way to build a practice, sort of good old fashioned sort of being around and taking calls from anybody who wanted to, you know, send a patient anytime. And so I worked really hard to make sure that my outcomes in the structural world were just exceptional. And I would do little things like at the end of the case, I'll usually send a picture, a photograph of the valve before and after it's repaired, and a short video clip of the completion echoes that the referring cardiologist can see. And so for me, it was really just about building the niche. The myectomy work, which was interesting, the cardiologist who had the Hokum clinic at our hospital just asked me if I would be interested in doing the cases. And so I started doing those. And I've actually transitioned that now. I'll be joining the group at Tufts Medical Center in Boston in the next couple of months, and picking up doing more septomyectomies and Hokum work as well as the mitral. So sort of transitioning in a way.
Well, the Tufts program has a well-known Hokum program, so congratulations to you on that. So you both touched on this a little bit, but I'm going to ask you to expand perhaps a little bit further. But before I get to that, I want to remind all the people in the audience that they should be free to ask questions via the chat box, and we'll try to answer them real time as we move along. So for both of you, what made you pursue your individual career path and where you ultimately wound up in practice?
So for me, the career path, I was a traditional resident, went through general surgery, 2 years in the lab, 3 years at the Cleveland Clinic. And so when you're finishing up, at the end of your training, there's a few things. Some are within your control and some are not. Being that, there's only so many jobs or certain jobs available in certain years. And so you go out and you look and you see what's out there. One of the biggest things for me starting out was I wanted to find a group that was busy. There was a lot of clinical work to be done. I really wanted to make sure that I was going to make that transition from being a trainee into a full-fledged surgeon successful. And so it was really important to find, a group that was going to nurture me and help me grow and help me get started. And that's really what I was looking for.
As for me, I love transplant. So that was the most important thing for me when I was coming out of training. I also did general surgery. When I started, I think there was one I6 program that was at Stanford had just started. I went into general surgery, wanted to do liver transplant. And then, I worked for Dr. Fred Chen in his lab and changed, my thinking and kind of fell in love with cardiac. And I did an advanced training fellowship at Columbia, focused on transplant and mechanical support. And I think, my love of transplant really directed me towards a job where I could be busy doing transplant and being involved with that. And along with teaching, I really do enjoy teaching. And so that was the other important piece for me, that I wanted to be involved in teaching. And I did have a geographical constraint, from family. And so all of those three main things, I think, directed me to where I am today. But also, like Mike said, you're left with a limited options, and you have to choose the best option for you that fits at the time.
And for both of you, we have a chat box question that I'd like to ask you. Any tips on how you remain academically productive? And for Mike, being at Maine Medical Center and having a lab is obviously not the norm. And for Marisa, you're at a large academic institution. Does the academic productivity just come, or do you have to look for it and create it and build it yourself?
For me, yeah, it is an interesting situation. I'm the only one doing research in my group, the only one that has a lab or does this kind of thing. But I think when you're in private practice, you just have to just keep reading. I read the journals, I try to get to the meetings, and hear what people are talking about and what's going on, and try and make the most of it. But I think, as Marisa was sort of echoing or saying before, was that it can be tough. The academic centers are generally the places that are going to get devices and trials first, and are going to have access to some of the newest stuff right off the bat. But developing relationships with industry has helped me and our group get in some trials and get some devices early on.
Yeah, that's great. And, I think that's great. In some ways, that private practice is more, willing to kind of try these things out, and where the wheels of academic medicine might be slower to turn because, you know, we're set in our ways a little bit in some cases. But just in terms of research alone, I think the benefit of being at a place like Penn is I have, you know, a wonderful group of residents who are eager to do research. And so a lot of it gets done, you know, without they can do stuff independently without me, and I can guide them. And so that's always been, that's a huge help for me. I think that's one benefit of having residents and medical students around.
And so I think a lot of what people think about, aside from career path and what options are available to them, they think about compensation. So maybe you can each touch on how you're compensated, sort of what goes into the formula of your compensation package, and how it's arrived at.
Well, mine's a little bit pretty simple. And Beth, would you mind going to the next slide, please? And this is sort of what some things to talk about in negotiating contract. But as far as my salary goes, I'm straight salaried. There's no incentive for volume, for quality, for anything. I make a straight salary, and that's it. So.
Yeah, mine's a little bit different. You know, I guess people might not think of this as an academic center, but we had 3 tiers of compensation, and it was based largely on our clinical productivity. Now, of course, this changed a little bit with coronavirus and people recognizing that clinical volumes are changing and it's a dynamic environment. But we had a kind of a baseline salary, and then we had 2 tiers above that, depending on how clinically busy we were, kind of, you know, an incentive and then an aspirational level. And 85% of these steps are based on our RVUs and the number of cases that we do, major cases. And 85% was clinical productivity, and then the other 15%, 5 was academic productivity, and 10% was being a good citizen, which was kind of generally for most of us is just a gimme.
I don't know how you describe being a good citizen, but but I think that's great.
Yeah.
And so obviously between academic centers and private practice, or all the different employment models, whether it's academic or private practice, I think it's important as to who you report to. Classically, on the academic side, you report to your division chief, who reports through your department chair, who then reports up through the dean. But even in academic medical centers, there are employment models where you don't necessarily go through that reporting structure and you report to the CEO of the hospital because they're the ones who are paying you. And on the private practice side of things, there are circumstances where you are either hired by a group and you report to the group, or you report up through some sort of larger medical group, which could be multidisciplinary, or you report up through the CEO of the hospital or some sort of health system. So maybe you can each say what your reporting structure looks like and what that hierarchy consists of.
So for me, it's, you know, there's a chief of cardiac surgery, a chief of our heart vascular institute, and then above that is the chief medical officer of the hospital. My contract is through the multi-specialty group that all physicians belong to. So it gets a little bit confusing at times with that, but in general, it's, you know, fairly straightforward. And if I want, you know, a new device or something like that, I just go through the normal channels of talking to the chief or talking to the chair and work it out.
Yes, for me, I report directly to the chief of the cardiac surgery division, who also happens to be the head of the Heart and Vascular Center. And he is very involved in everything. And so I report to him directly, and occasionally the CMO gets involved as well. And very cordial relationship with the CMO. In terms of my contract is with the School of Medicine, and which is part of the university. And that's actually how my pay is structured as well. Part of it is university based, and part of it is from the School of Medicine.
And jumping on that, there's a question from the chat box. How are relationships with industry developed, and when does that start? And is it different for the two environments?
Well, it's interesting. Yeah, I would say it's probably different. For me, it started during my training. When I was in Cleveland, I kind of got to know the people who were, that were selling our valves and selling our equipment. And, when I took the job in Maine, they sort of helped me get to know who the people were in Maine. And interestingly, a lot of these people have moved up within the company. And so, now as I'm moving down to Boston, getting ready to meet with a guy who was a valve rep in Cleveland, but now is sort of one of the national reps for some of the transcatheter valve technology for Abbott Medical. And so, we've just sort of kept in touch over the years, and now, those have been good relationships to understand what's coming down the road, what opportunities there are, and things like that. And for me, it's been a lot of fun to be part of that innovation and that work with industry.
Yeah, I think industry will find you. I don't think it's ever a problem. I mean, they want to have you use their devices, and I think it's very easy to get involved with industry. In terms of bringing some of the devices on, it could be a little bit of a complicated process to get it through whatever channels the device needs to be brought through to get it into the hospital and using it in patients. And part of it is financial, and part of it is just trying a new technology. But again, I've known guys from when I was training in Boston and in New York, and then they put me in touch with people now that I'm in Philadelphia. So I think industry does a good job of just seeking surgeons out.
And do you think there's room for residents to get involved with industry?
Yeah, absolutely. I mean, I think they often sponsor educational sessions. I've worked with industry to help bring some educational sessions. It's a little bit different during these times, but I think they would like to definitely start to get to know residents, because they know that they're the future of the field.
Exactly. I agree.
Mike, what's your experience been?
Yeah, absolutely.
Okay. So,
yep.
So one last question as we start winding down the session. Tell me what your typical work week looks like. And Mike, since you're straight salary, is there any compensation for the research that you do, or does that hurt you in terms of your compensation? And same thing with Marisa, are there requirements for education or research that are built into your compensation package? And so what does your actual work week look like?
Great question. Beth, I think we have one more slide there. I think. Have that flip over. So yeah, my work week is, I operate 3 days a week. So Monday, Wednesday, Thursday, I've got the OR. So I do, do 2 cases a day. Tuesday, I'm in clinic. And then Friday, I'm in the lab. And, I don't get necessarily penalized for, for the lab time. I don't get any extra money for it or anything like that. It's, but I just have to make sure the clinical work is done. So on Friday mornings, I'll usually go around to make sure everything's okay. Occasionally do a case on a Friday. And if, somebody calls me, obviously I'm available. So I try to keep my clinical work up front.
Yeah, and just briefly for me, Monday's my clinic day, and sometimes something comes in over the weekend or from later in the week, and I might sneak on a case in the afternoon. And then my block times are Thursday and Friday, and so most of the time I spend either in the ICU or taking care of patients still. But I'm meant to be doing research on Tuesdays and Wednesdays, and specifically in response to your question about, am I compensated for my academic productivity? Yes, a small percentage, 5% of my salary, of my pay comes from academic productivity as well.
Great. So I want to thank our panelists and Dr. Pickens for being active on the chat box, and obviously to the STS for hosting this session. I want to thank you all. We hope you learned something, and we hope that this will be helpful to you in your future. Thanks very much.
Thank you.
Thank you very much, Lenny. Excellent session. We'll move right into our third session. I think there's some questions on the chat that will be answered here. And the session is key steps to finding the right job, ably moderated by my friend Stacy Sue and Betsy Dexter. And with that, we'll start right away. Stacy, it's all yours.
Thank you, Fez. So this next segment focuses on making the transition from a trainee to a junior attending. And it answers questions as an attending, what one wished one knew, as a trainee, which factors one ought to seek in looking for a great match for a first job. We featured Dr. Pauline Go from Penn State Hershey and Dr. Erin Keim from Chicago to give insight into poignant aspects of their experiences while starting out. Our QA moderator is Dr. Betsy Dexter from Roswell Park, and I'll first have each of the panelists introduce themselves. Dr. Keim.
Thanks, Stacy. My name is Erin Keim. I'm a cardiac surgeon in the Chicagoland area. I'm in my second year of practice and graduated from an integrated program at the University of Southern California. I'm part of a large private practice of over 20 surgeons specializing in cardiac, thoracic, and vascular surgery. My primary hospital is a 400-bed community hospital, but I'm on staff at about 15 different hospitals, including an academic medical center in the area. And I provide coverage at a few different hospitals on an as-needed basis.
Thank you, Dr. Keim. Dr. Go.
Yeah, thanks, Stacy. And then thank you for the to the STS too for the opportunity to be part of this panel. So my name is Pauline Go. I'm an academic general thoracic surgeon and a surgical intensivist at Penn State Hershey Medical Center in Hershey, Pennsylvania. I completed my general surgery residency at Henry Ford Hospital in Detroit, followed it with a surgical critical care fellowship at the University of Michigan, and then finished with a cardiothoracic surgery fellowship at the University of Iowa. I've been in practice since September 2019, and this is my first job. Currently, I work with two partners within my division, and we're a kind of a rural academic center. Our practice pretty much encompasses all aspects of general thoracic surgery with the exception of lung transplant.
Thank you for both of your introductions. Each of your job positions is very different in nature, and you're both in your second year of practice. As you've had time to reflect upon the job search, what were important determining factors when you decided upon your current job? I'll start with Dr. Go.
So as mentioned in one of the earlier sessions, mentorship is extremely important. And that was actually my #1 priority in finding my first job. It was to find partners that would also be good mentors. Essentially a partner that's going to be willing and able to basically back me up without just basically taking over my cases and essentially turning me into a fellow again. At the same time, a good mentor will also shield you from any major complications or bad outcomes that occur early in your career. So that was my #1 priority. Another equally important attribute I was looking for was just the overall institutional culture. I was looking for a work environment where there was strong camaraderie with other surgeons and other physicians, good collaboration with a lot of the departments that you work closely with, for example, pulmonology or interventional pulmonology, GI, oncology, radiology, radiation oncology. So I was basically looking for a collaborative, collegial environment that actively discourages an eat what you kill type of mentality.
Thank you, Dr. Go. Dr. Keim?
In looking for a first job, location was a big motivating factor for me. I also wanted a job where I could practice almost exclusively cardiac surgery. I looked for, I think, like Pauline, a position with a clear plan for mentorship as I got started, but then with a plan for progression. So ultimately independence and taking over a program.
Could you both elaborate on which aspects you most enjoy about your current job with regard to helping you to achieve a personal / career satisfaction? Dr. Keim?
Yeah, so I'm part of a very well-established group, and that really allows for an exceptional work-life balance for me. I have a busy practice where I do a mixture of cardiac and vascular. I do about 170 to 200 open heart cases and 50 to 75 vascular cases a year. That's enough of a volume to keep me busy between 9 and 5, but it also allows me to be home in the evening with my wife. I have a lot of good mid-level support, which offloads much of the floor and clinic work, allowing me to focus on patient care and operating. The flexibility with my time really allows me to feel like I have the best of both worlds. I get to do what I love, but I also get to spend time with the people I love.
Thank you. And Dr. Go?
Yeah, so, I have a lot of flexibility to have a very diverse practice that it allows me to practice both thoracic surgery and spend some time doing surgical critical care. So I have extremely supportive partners. They accommodate to actually make this happen, to allow me to have this type of a practice. For example, they make sure that I don't get this obscene amount or disproportionate amount of call between the two services. And so that's a very important, again, going back to having the right partners and mentors is a very important aspect of this. But in addition to that, I have a lot of opportunities just to participate in our education and mentoring of medical students, residents, and our fellows, as well as a lot of the independence and resources here to develop any new educational programs, anything that I come up with that I want to try out. I have plenty of support to pursue any kind of academic interests I may have without actually having very strict requirements for publishing, but still having plenty of support whenever I do want to do some research. And then as well as quality of improvement initiatives, again, plenty of opportunities, plenty of resources to help those move along. So overall, I'm busy, but I'm not overwhelmed. And, I just want to, again, echo what Erin said is that, I have a very healthy lifestyle. I have excellent work-life balance. And despite what, we may have been trained to think in surgery residency, we don't have to sacrifice family and an actual decent lifestyle for surgery. So it's very doable to balance both and frankly, never bored.
Thank you both. Mentorship is clearly a key element in making this transition from a trainee to an attending surgeon. And we've already heard about its formative importance in the previous segment. Can you give us explicit examples of how your senior partners have demonstrated good mentorship to you? Dr. Go.
Yeah, so my partners, they're always available, always, whenever I need a second opinion on, let's say, a difficult case, or if I just need an extra set of experienced hands or eyes in the OR, or just an intra-op consult. I can call them in the evenings if if I'm on call and I get a challenging case, I can run it by them, and they'll come in if I need some help. During my first few months here, they would make sure that at least one of them was immediately available here just for assistance whenever I had any big cases scheduled. For example, my first lobectomy. they would stay in house till I was done. And sometimes that would be 9 p.m. You know, I guess being a junior faculty, I didn't get to start till the afternoon. So, you know, my case would end at 9. They would hang out till they saw that I'd gotten through the key portions of the operation. So the other thing too, that's a very underappreciated, something I've never actually even thought about was, you know, they actually provide a lot of guidance regarding career advancement, things that I would never even think about on my own. My you know, division head, he will actively, and I think this was mentioned in one of the earlier sessions, but he'll actively promote or endorse me out in the hospital, introduce me to some of the you know, key people in the departments, so that they get to know me, as well as out in the community, just to make sure I get referrals. You know, things like that. And overall, I think one of the key things I want to keep emphasizing is that they provide support and guidance without actually compromising my independence as a junior attending. So, yeah.
Thank you. Dr. Keim?
So I took my job with the understanding that I would work with a surgeon who planned to retire in about a year. When I started, we laid out a framework for how he envisioned me progressing. So that started with me assisting him on his cases. And then, you know, he started passing me for cases fairly quickly. So at first it was just simple things like single vessel CABGs. And then when I showed I was capable, he started letting me operate more and more independently. Beyond that, I guess similar to what Pauline was saying, he was available for advice on patient management, selection, operative management, but he also gave me space to provide care as I saw fit. So I felt as though I was independent and not his fellow. My other partners, since it is a large group, have sort of followed suit. They're available when I need help or want an opinion, but I have plenty of room to practice independently.
You've both expressed a high level of job satisfaction and career fulfillment early in your careers thus far. If you were able to change one aspect of your current job, what would that be, Dr. Keim?
Because I'm part of a large group, I operate at different hospitals relatively frequently. What that means beyond simply driving all over the place is having to operate with a group of people you either have never met or don't frequently work with. It's something I've gotten used to as I approach 2 years in practice. But as a new graduate doing open heart cases, it can be stressful. I bring it up not so much because it's something I want to change anymore, but it certainly wasn't something I considered when looking at a job. You know, when you start in practice, finding your routine is key, and trying to do that while working with people and instruments and supplies that aren't your norm can be difficult, and perhaps it's something to take into account as you look at jobs.
Dr. Go, please.
So I guess I wouldn't say that there's one particular aspect of my job as a surgeon, or I guess as an intensivist, that I would want to change, just because in general, I do have a lot of control over how I want to structure my practice and the flexibility to make reasonable changes to my practice. But I think anyone who's in academic medicine would probably tell you is that there are always several areas for improvement at the institutional level that can really be a real big source of frustration and extremely difficult to change. So those are kind of the things you battle in academics. Now, I guess if I had to choose one aspect though, I would say that I would want to establish specialty surgical teams. You know, unlike Aaron, I don't rotate at 14 different hospitals, but sometimes it feels like it when I don't get a consistent OR team. So basically having a regular OR team that has familiarity with just routine thoracic surgical procedures, or even the surgeons, knowing the instruments, having the experience to actually troubleshoot the equipment that we normally use. That's I think it's kind of an undervalued trait. And so Certainly that's something I would push for if I thought that was something we could get here.
Thank you both for sharing your experiences with our audience today. In spite of the differences between your job descriptions, your accounts have much in common, including the importance of strong mentorship, leaning on the expertise of consistent and reliable support staff, seeking flexibility in order to find that desired career balance and achieve personal fulfillment, and planning standardized approaches to carrying out your clinical practice within the unique constraints of your job. I don't think we have much time for opening up the floor, but are there any other questions?
Stacy, I had a question from Dr. Bora, which I think is an important one. How do we start building trust with partners when we're new to a practice? I gave my opinion, but I would welcome your opinion and the opinions of Dr. Go and Dr. Keim.
I think that's a really important question, because on first entry into a new job, each party is a bit of an unknown in spite of clarifying expectations on both sides. I think that open communication is really important, and especially, for example, in terms of tough cases, just discussing plans out in the open and entertaining questions up front. I think that would be my advice. Dr. Keim?
Yeah, it comes to mind, what they talk about as the traits of a good surgeon, affability, availability, and ability, right? So you have to demonstrate all those things to your partners. You have to, be available when they need you, when they need your help. And you have to demonstrate your ability. So whether that comes in the operating room or patient care or decision making.
Dr. Go.
Yeah, I definitely agree with everything you both said. I think additionally, as much as we emphasized that a good mentor allows you to grow independently, I think it's also from our end as being junior attendings, listening to our partners when they give us advice and saying that, based on their experiences, what they would do. And I think actually sitting there and listening to them is important. And showing good judgment by not always thinking you know everything, by running things by them when you have something that's a little bit not so straightforward, as well as I think getting over that idea of, I'm too good to do a decortication or small case, especially when your senior partners, maybe they offer them up to you. Some junior attendings may feel that they're being dumped on. That's, I don't think that's true at all. I think a lot of them are saying, hey, this is a good straightforward case. I think it'd be good for you to do or to take the fellow through. So, getting over that mentality of, I'm an attending now, I'm not a fellow, I'm not going to do this small case. I think that's a big one. And again, just like being available to help if they're, let's say they get a case like that, a small case, and they just aren't able to do it. They don't have the time, just kind of jumping in and say, hey, I'm free, I'll take care of it.
Thank you both for your opinions.
I think,
yep.
Just one more thing. I think it's important to help your partners when you first start. Not only can you learn a lot from them, but nothing builds trust like getting into trouble with your partner and doing a tough case. Offering opinions, showing them that you have experience with dealing with tough situations. I think that's one way that my partner and I grew a lot together. And I think it really helps the relationship develop.
Thank you. We'll wrap up this session and move on. Thank you both.
Thank you.
Thank you very much, Stacy, Betsy. Really terrific session, and I think a lot of pearls of wisdom for our residents and fellows. We'll move on to the next session, which is important, and that is achieving financial security, and again, moderated ably by my friends, Melanie Edwards, Fred Chen, and we have two terrific speakers as well, Sinu and Manisha. So on with the next session. Thank you.
Thank you, Dr. Bora. And so as much passion as we all have for our job as CT surgeons, we actually do expect to be compensated for our work, and how we manage our finances can make a big difference in our lives. It is known that poor financial health can actually increase the risk of burnout. So we have three experts today. Our digital moderator, Dr. Fred Chen, who is Chief of Cardiac Surgery at Tufts University, Dr. Manisha Shende, a thoracic surgeon at the University of Pittsburgh, and Dr. V. Sinu Reddy, a cardiac surgeon in private practice in Nashville, Tennessee. So I'm just going to jump right in with Dr. Shende and ask you, as residents look towards the transition to practice and the corresponding increase in income, which can feel like a windfall after several years of sacrifice, what should the top financial priorities be when starting out?
Is that better? Yeah. Sorry. It is nice to look forward to a bigger paycheck after being a resident for so long. And I really believe that some of that money you should enjoy. So it's not all about putting it away and paying bills and catching up on loans, but really, really have a focus on long-term goals. Spend some money, but also save. I'm a big believer in saving for the future.
Excellent. And as residents look forward to saving, can you expand on beyond saving? Are there other priorities like, insurance and other things that they should kind of set up when they're going, just the way you kind of set up your practice in the hospital?
Absolutely. Having a healthy financial plan starts at that point. In fact, it should have started in your residency. I believe that all of us, especially during residency in academic centers, do have access to starting your 401k plans. And I think most of us take advantage of that. You should. So you should have some kind of a goal already set. As you start into your first few years as an attending, you need to make a long-term plan, whether that plan includes maybe saving for a home, saving for children's education, or saving for yourself, for your retirement for the future. Make a plan and try and get help with that plan if you need to achieve your goals. So the first thing is to know what you want and how much you're willing to spend to get it. And then second, make a plan to get to those goals. That should include insurance, health insurance, disability insurance if you haven't already bought it as a resident. Buying disability insurance as a resident is a lot cheaper. And so really that's the time to do it. Don't wait too long. As we get older, it gets harder to get good insurance. So don't wait too long on that.
Yeah, and also look for own occupation specific insurance.
Correct.
So just to pivot, Dr. Reddy, one area that can be difficult to prioritize is how do you manage, say, paying off debt versus building savings? Does the type of debt matter? And when you're looking at student loan debt, mortgages, consumer debt, what's your advice in this area?
Yeah, I think that's very important, debt management. I want to also just back up and kind of give an overall framework. I think one of the most important things residents transitioning into young either faculty or young partners in a private practice need to do is really think about defining what personal financial security is for yourself. Is it really meaning retiring by a certain age? Is it meaning, just like Manisha said, educating kids? Is it ability to fund a foundation? Is it being debt free? Or is it accumulating certain assets? I think you have to really define that structure of what is financial security. The other important component is you have to understand that during your career, millions of dollars will pass through your hands in the full length of your career. And it's really the decisions you make with what happens with those dollars, it really will determine the final outcome. But all of you will have millions pass through. Now, getting specifically to the question about debt, I think the number one thing to understand is that debt is a useful thing to use and to have, but it can also cut both ways. And particularly variable rate debt can be particularly hazardous. So I think just as you pointed out, Melanie, that the important thing to do is categorize or put into buckets where your debt is. What is long-term and fixed in terms of rate, and what is short-term and variable. All of them can have appropriate usages, but in general, as all of us know, variable rate debt can very quickly move against you. So that typically should be the debt that you pay off or you really shouldn't carry, such as credit card debt, consumer debt, as you pointed out. Other debt, such as mortgage debt, right now happens to be probably the lowest we'll ever see. If you haven't refinanced, as Warren Buffett said, do so now and capture that, because in a way, that's the cheapest you'll ever be able to have a large asset like a home and pay literally 2.5% to 3.5% to own that asset, while you can earn more with your money and other investments.
Thank you. Excellent advice. So as we look at the area of personal finance, it can seem quite overwhelming. And one of the first common recommendations made is to hire a financial advisor, get help, don't try to do it yourself, it's too complicated. So I'd really like to get your perspective on this. Dr. Reddy, we'll start with you.
Yeah, I think, advisors, again, just like we talked about with debt, can cut both ways. I think there are advisors that are set up to make you money and themselves a lot of money. There are advisors that are set up to be purely advice and you pay for that advice. The smartest information I was given on this was actually by a heart surgeon. It was Dr. Ellis Jones at Emory. He said to a group of his residents as we were graduating, he said, you should probably have 2 advisors. He goes, if one tells you to do it, you better check with the other. If both tell you to do something, you probably should do it. If both tell you not to do something, you probably shouldn't. And then if they're split on it, you should do something, you better give it a lot of thought. But I would just say that, yes, advice is important. I don't think all of us should understand that we're expert in our field. We're either an expert in our thoracic surgical field, in our cardiac field, or whatever subspecialty we pursue if you're a congenital surgeon. And don't think that you need to be an expert in personal finance or investments. I think it is important to seek out through either your friends, relatives, or trusted individuals. And it doesn't mean that the first time it's going to be perfect. You may have to try a few, but you'll find eventually that a good advisor is very, very important to have.
Dr. Shandy.
Yeah, I think that you have to be very honest with yourself as to what you realistically can do. Do you have the time to research investment vehicles, investment options? Do you have the interest in doing that? Will that time and interest take time away from your family? Maybe, you don't get to attend your children's functions because, you're playing with your money. If that's the case, get a financial advisor. But if you do, make sure that the fee structure is what you want. There are many different ways that financial advisors make a living. The one you pick should be somebody who has a fiduciary duty towards you, which means that they act in your best interest. And typically, those will be fee-based, not working for a particular company that sells their own products, or commission-based. They obviously work for themselves. So I don't think there's anything wrong in getting a financial advisor. I use one. As Dr. Reddy mentioned, I've changed my financial advisor over the past few years because, as my assets accumulate, I found that going to a different company got me a lower rate with them. So, not a big deal. I pulled my money, put it into some other company's hands. But I do use them. I don't think there's anything wrong with that.
Yeah, but I think that's all great advice. And I think the key is know what you're paying for. Make sure that the advisor is not making money on selling you expensive instruments because they see a thoracic surgeon or cardiac surgeon. So they see dollar signs, which, is probably appropriate. Look at assets under management fees as well. When you're starting out, that's not going to be that much money, but if you get to $1 million portfolio, they're making $10,000 a year. And you have to think about whether or not that is a good value, or if there are cheaper ways to do it with a purely just flat fee-based advisor.
thought on that, Melanie. I think it's really important. You as the consumer or the customer, just like a patient, may turn to you and say, well, how many of these operations have you done? What's your success rate? You need to be very, or your advisor should be very transparent with you. You should be able to look them in the eye and say, so how are you going to get paid and what do you get paid on this investment? And if they can't disclose or tell you that or not straightforward, then I think it's time to look for someone else, because that's a very reasonable question to ask. And furthermore, most of the big financial firms such as Merrill and Goldman, they are required to provide you what their total fees are every year now.
Excellent, thank you. So, Dr. Reddy, I'm going to start with you. Where do you see CT surgeons making mistakes in their approaches to finance? And what are the things that we sometimes get wrong that our residents can learn from?
Well, I've made these, and I'll tell you just quite frankly, the worst place to get your investment ideas or your investment actions is from the physician's lounge. And that's, let's try and listen to what the guy next to you or the orthopedic surgeon or your other buddy, what they did. For example, right now, what's going on, I'm sure all of you have heard about Reddit and what happened with the shorting of GameStop and so forth. But that doesn't mean that you should run out and now suddenly start trading in GameStop options or similar. Same thing with Bitcoin. About 5 years ago, I was at a meeting. A lot of my fellow CT surgeons were buying a ton of Bitcoin. I dabbled and bought a little bit, really didn't do very well in it. And then look at, it has a lot of volatility. So I think in general, hot investment ideas are an area you shouldn't really tread in. What I think has worked much better for me is the bucket approach. I try to think of buckets of where I put my investment dollars. Obviously, stocks have done the best over the long period of time, and you don't even have to pick an individual stock. You can just pick an index. Similarly, some component of fixed income, a little bit of real estate, but all that other stuff you do, whether it's your E-Trade account, your venture capital investments, hey, it's a great little company that my friend is starting. It's going to be the next, app-enabled solution to something in healthcare. All of that should never be more than 5% of your total savings.
Dr. Shandy?
I think, and this again is based on some personal experience, I think one of the mistakes we make, that I've made, is sometimes spending beyond your means. I think it's very, very important to establish a budget. That budget should have a built-in a portion for play, for fun, for travel, those things, and then you need to stick to that. Life is for living, so you should definitely budget for fun, but don't overspend. Think of how much you make and how much really should be a flexible spending income. One of the things that this COVID year has taught us is that we are not immune to financial insecurity. I know colleagues who have lost jobs, who have lost months of income. One of my best friends is a surgeon, and she had to go 2 months without a paycheck in a private practice. So yeah, we may see millions in our lifetime, but right now nothing is guaranteed. So definitely plan for the future.
Dr. Reddy, what other kind of COVID-related lessons do you think we can learn that are applicable to our personal finance? This has been a year unlike any other.
Yeah, it was a very unusual year. And in general, as Manisha said, income may have been down. Certainly mine was, just like you pointed out, in a couple of those months when things went slow. Fortunately, we planned for that. That's important to have one of those buckets to be an emergency fund for savings. Ironically, last year was also an amazing year for investments. So I think the specific thing to point out is don't panic. In March, for example, when the market went tanked, nearly 15 to 20%, a lot of people that I know said it's time to get out. There's a pandemic. Let's get out of stocks. We just need to have cash. That was absolutely the worst thing you could do. If you had stuck to a plan and dollar cost averaged and actually either put any amount of money into the market in March, you would have been far better off by the end of the year. Those are some of the most spectacular gains that anyone has seen in recent memory. So I think, as you point out, just because a black swan event comes or a pandemic occurs, I think you again follow one of the people I like to follow, which is Warren Buffett. So when others are fearful, that's when it's time to be greedy. And when others are greedy, it's time to be fearful, just like maybe with some of the recent excesses we've seen in the market.
That's great advice. And I would also echo that having a pre-planned written financial plan, number one, looking at long-term savings and long-term investments and not trying to time the market are ways that we can really stay ahead. The market's just going to go up over time. And if you plan for 20 years, you know, career-wise, just ride out the bear markets. They will pass. As we close, I just wanted to touch base with each of you and see if you had any closing advice for residents. Dr. Shendy?
I think, again, you know, the COVID year has taught us, but really we should think about this all the time. Have some kind of a disaster plan available and made for your family. This disaster plan should include financial disasters as well. You know, we should all know what things cost. It's very easy to know what your mortgage amount is, but you don't necessarily include the other costs, insurance, utilities, you know, things like that. So really have a good idea of how much you spend just to exist, just to live, just to have, you know, that roof over your head. Have a place where all of your financial documents are saved that are accessible in an emergency. So having it in a cloud may not necessarily help you, you know, if you don't have electricity or, you know, some kind of a natural disaster happens. I think it's a good idea to have these documents available, even for your family, if something should happen to you. I'm not sure, Sino, what would you add to that?
I think you're spot on. I think my wife says this to me all the time. For your partner or your spouse or significant other in your life, it's important to have that financial paperwork or document vault. And that should be all those key documents. It's a financial power of attorney, it's a living will, it's your healthcare power of attorney. All of those documents are kind of a core thing you should keep in a couple of places, hard copy and of course in some digital vault. Many of your banks and other places will actually offer you a digital vault. Number two, I'd say, is plan and then reassess your plan. You know, don't let finances or money consume you or become a burden. Really make a plan and then execute your plan. And then in year one, after you're into your first year one of a job, I think it's important to reassess. Then kind of redo your plan, got your advisors, execute your plan. And then year 5, kind of look back, see where you are. Do that at year 10. I'm doing that now at year 20. But I think it's just important to do that from time to time, but don't do it every day. It's just like Fred, I think, is saying on the chat. On the market, you don't need to check your stocks every day. You don't need to check them every week, but you should check them probably every quarter or once or twice a year.
Consistency and saving is really important.
Thank you, everyone. And also, I think we have a list of resources for more education that can be emailed out or on our next slide. Appreciate your expertise.
Thank you.
Thank you. Nice to be with you.
So Melanie, thank you very much. Thanks, Sinu and Manisha, Fred. Excellent session. We'll move on to our last session. We're running a little bit behind time, so hopefully we'll try and make up a little bit. And this is achieving a work-life balance integration. And I look forward to moderation from Daniela. Sidhu, my good friend, is always in the gym, so perhaps he can speak a little bit about that. And of course, Ben Way has his own way of spending time that I'm sure he'll talk about. So let's get on with the final session. Thank you, folks.
Welcome, everyone. Thanks for joining this panel. We've had several great sessions already. I'm Danielle Gottlieb-Sen. I'm a pediatric and congenital cardiac surgeon at Johns Hopkins. And thanks to the organizers for the opportunity to moderate this session. The topic of the session is work-life integration, and we have some terrific panelists, and we can learn a lot from their experiences. The format of this panel will be the introduction of the panelists and then time for 4 prepared questions. If there's time, we'll highlight some questions, as has been done previously, from the audience that are coming to us by way of the chat. So I'd like to introduce 3 people. Both discussants were part of traditional track programs before I6 existed, Dr. Lindsay Pritchard and Dr. Ben Way. We also have a moderator of the chat, and I'll ask Dr. Sidhu Gargandaran to introduce himself as well. So I'll have them introduce themselves next.
I guess I'll go ahead. My name is Ben Way. I'm a general thoracic surgeon here at UAB. I'm about 7.5 years out from finishing my fellowship at Duke. Do probably about 600, 700 cases a year. I have probably 6 kids between the ages of 1 and 12. And, you know, 2 of them, the 2 oldest ones, actually play competitive soccer. And so I actually travel quite a bit with them to various places. I'm also the program director of our residency here and have a 3/8 appointment at the Birmingham VA. And finally, I serve on the JTCVS editorial board.
Dr. Pritchard? Thanks, Dr. Way.
Hi, thank you again for having me today. I am 2 years out of training. I finished a traditional fellowship out of Yale, New Haven. I am currently specializing in adult cardiac surgery. I'm the chief of cardiothoracic surgery at Walter Reed, a national military medical center. I'm active duty US Navy as well. I spend the majority of my time between both Walter Reed and I do spend time back up at Yale New Haven still. I'm a clinical instructor in cardiac surgery there. I have 3 young children between the ages of 3 and 7. I've had them in various stages of residency and fellowship. And so that's a little bit of my background.
Thank you. Dr. Gangadharan.
Thank you. I'm Sadhu Gangadharan. I'm one of the thoracic surgeons. I'm the chief of thoracic surgery at Beth Israel Deaconess. It's nice to see Doctors Robich and Edward, past alums of our program, on today's session. And I have 4 kids ranging in age from 13 to 21, and I'm about 15 years out myself.
Great. Well, a lot to be learned from this panel. We've all heard a lot of advice about how to be successful, and we're sure that this group of students and residents are aiming for the same. So let's start by asking, what's your definition of a successful life?
So, I'm really more interested in how you define a successful life, in the audience, and I'll say what I think is applies to myself. But, I think you need to decide what's important to you and not necessarily your chairman or society or your peers. And, success really and a successful life doesn't look the same from one person to the next, personally, I want to be a busy clinical surgeon, develop kind of new skills in the operating room, contribute to promoting and sharing scientific knowledge, and feel like I'm growing as a surgeon and an educator. And on the other hand, I want to do this while keeping my family as my #1 priority and being around to raise my kids and spend quality time with them. But I really think you need to figure out for yourself what your ideal life looks like.
Awesome. Dr. Pressure?
I would echo that 100%. I think when I look at what a successful life is, it's a kind of an integration of personal, family, and career aspirations. So in every single day, there's a little bit of a give and a take that occurs. But at the end of the days, when that approaches, I want to be able to look back on my life and know that I didn't leave anything left undone, that I was able to accomplish some of the things that personally and professionally satisfied me. And raise healthy, successful, well-adjusted children that contribute to the world. So I think all those things together are what I consider a successful life.
Well, that's wonderful. There are many terms to describe how you move between the different realms of your life. And I think both of you have alluded to this, your home lives and your work lives, and maybe there are other parts of your own personal life as well. Like in the presidential lecture yesterday, we learned about Dr. Durani's great expertise in playing jazz music. Maybe the ways we describe the work and life relationship are just semantic, but when you're thinking about the components of your life, is your goal to balance work and life, or to integrate your work and your life, or is it something else? Do those words matter?
I think they do matter. I think when you talk about balance versus integration, I think balance implies that one's got to give in any situation. But I think when you talk about integration, you're really kind of incorporating all of your different aspects into one, and that becomes a whole in essence of itself. So I think that the way you view things and the way you structure your mindset on how successful you're going to be, and your expectations with your life and your integration in certain aspects of it, I think that plays a good or a key role in things.
Dr. Way?
Yeah, so I think it's a kind of a terminology thing here. I think, what we've seen this past year with COVID and the using a lot of remote meetings and teleconferencing is that I think integration has become a bit more achievable. But sometimes it's hard to kind of, obviously bring home to work, and it's sometimes messy to bring work home. And so I think, more than anything, I think it's really important to try to, figure out how to triage and prioritize, and understand that you don't have to go into the hospital every single time you get called. You need to learn how to manage patients and situations kind of from afar, and know when you have to be there and when you don't. And I think it's a lot easier, obviously, if you have residents or the staff to help you with this.
I think it's also really important. I'm just going to add in there one thing: to manage your expectations of how much you can actually bite off. I mean, there is a limit to, what we can do as people, and there's a limit to hours in the day. So, it kind of goes into integration. There are some times in your life where your professional aspirations are going to kind of be at the top forefront. And there are some times in your life where your family needs you, or you want to be kind of involved in that family aspect a little bit more. So I think that plays just an understanding of what your priorities are and kind of your capabilities.
Yeah, so I wanted to ask, just sort of dovetailing off that, is it possible to achieve this integration of work and life? And I think both of you have spoken a little bit to that, but I guess I was looking for some more input. I'm sure that the residents and students who are listening might have some questions about whether it really is possible, given that that starting a career in cardiothoracic surgery can be kind of daunting. So anything else to add there?
Yeah, I mean, I absolutely think it's possible. In fact, I think it's desirable and even really necessary, for one to be happy in life, to achieve that kind of balance. And just remember too that, balance looks different for different people. One person may be happy spending every waking hour in the hospital while most wouldn't. But that's okay. Keep in mind also that when you go from being a resident to an attending, your ability to control your schedule changes and improves drastically. And so you can kind of decide how productive you want to be and how to manage your time, which is something that's really difficult to do as a resident.
I would echo that 100%. I think it's efficiency in time and time management skills. You have a lot of ability to reformat your schedule to what you see fit. And I didn't realize that for the first year that I was out, and this second year is really kind of how I've been able to manage my schedule much more efficiently. So I'm spending more time at home, less time kind of waiting around for stuff that I don't need to be waiting around for. And I think it's allowed me to kind of integrate much better. It's a whole different world when you're an attending than it is when you're a fellow. Again, you control what you want and how you want to integrate things. So efficiency is really key.
I guess sometimes, even though we're trying to produce integration, it's important to make boundaries. And I see Dr. Way's note in the chat that he's locked the door to the room where he is right now so that he won't have too much integration of his 6 children into this panel. So we appreciate that, Dr. Way. Well, given that you've demonstrated success in multiple realms of your life, what pearls for a successful life do you have to share with the people who are on the call, on the Zoom meeting right now, starting out in a career in cardiothoracic surgery? And are there any pitfalls that you could advise people or warn them about before they fall into them? Start with Dr. Prescher this time.
So I think my biggest key would be flexibility. Learn how to kind of roll with things your first couple of years out. Be flexible with yourself and your family. Know that it's going to take a little bit of a learning curve to kind of rechange your schedule, reformat your expectations, find your kind of efficiency mode, and have a plan. Have a plan for 1, 5, 10 years out. But again, going back, being flexible with that plan and understanding that things change. I think it's important that we accept advice and not kind of get out of fellowship thinking that we've done it all, seen it all, and we're ready to kind of take on the world. I think it's good to be motivated, but it's also important to be wise and know that you haven't seen it all and that it's a continuous career of learning. And it's really lifelong learning, and find the people in your life that are going to support you and provide you with that advice. And even the people you think may not be giving you good advice, there's always some advice and there's always something to be learned from every case and from every interaction. And then I think, getting into a routine is important too, and finding a groove.
Great. Dr. Way, what can you add?
Yeah, I think Dr. Prescher mentioned it earlier, but I think efficiency is pretty important. You know, not just in the operating room, but with tasks that you do outside the operating room, whether you're writing papers, doing reviews of articles. You know, speed isn't everything, and it's not even the most important thing. But I think the faster that you and your team work, the more time you'll have for other things. The other thing that we haven't really talked about is you know, consider finding a hobby or an interest, and remember to take time for yourself, you know, apart from work and apart from your family life, and just understand your need to recharge at times, and do stuff, you know, for yourself. And finally, in terms of another pearl, I think it's important to get help, you know, in the OR professionally, but also outside. You know, I think it's a good idea to embed yourself into your community and help other people when you can, and get help when you need it. In terms of some pitfalls that, you know, would be ideal to avoid is, you know, again, don't overbook yourself. You know, control your schedule. You don't have to say yes to every single thing. And finally, you know, I think it's important not to pretend to be someone that you're not. You know, I think you need to be honest with yourself, and flexible. You know, in junior years, it's obviously more difficult because you may have, you know, certain things that your partners need you to deal with, and your case volume and mix may be a little different from what you imagined or expected. But you still, you know, if you are honest with yourself, I think you'll feel better about your work-life balance, and if you mold your career based on your own goals and priorities.
Yeah, I think that's great advice. Thank you. And thanks for all the thoughts that you've shared today. I've seen a lot of questions flying by on the chat, and I think we've been able to answer all of them, and we're sort of running low on time here, but I'd like to encourage the students and residents here to contact people on the panel if you have further questions. I also wanted to emphasize the importance of the views that you've shared about following your unique path. I think it's super important, a path that integrates elements that you value and find most reward in, and that how you spend your time to some extent should reflect these priorities. I also appreciate the example set by the panelists who demonstrate that it is possible to value having a family, taking time for yourself, simultaneously being a busy cardiothoracic surgeon. So I'll turn it back over to the session moderators, and thanks again to the panel and our Q&A moderator for your time and for being part of this.
Thank you very much, Daniela. Excellent session. Really appreciate all the candid insights, and I hope, and I'm sure that our residents have as well. We're running over time, so we'll wrap this up. I just want to make sure that you have the contact information for all the panelists and our moderators. This will be shared on the STS website. This symposium has also been recorded, and I think will be shared on the STS website. So with that, just wanted to thank everyone again for the faculty for their time in putting together this session. STS support, particularly Beth, for all your help. And again, to my able partner, Betsy Dexter, for all her help behind the scenes. And we hope you had a good session, and we look forward to being in touch. Thank you very much.